following the wonderful. Hey everyone, thank you for joining us today for an informational webinar highlighting the Mom Map project, which is a comprehensive statewide asset map tool targeting social needs practices within prenatal care. If I haven't already met you, my name is Christy Degner, and I'm a Site Engagement Coordinator for MVC. It's nice to see you today, and I look forward to facilitating this webinar for you. So today's webinar will feature a presentation by Dr. Alex Peahl and Briaa Robinson of the Obstetrics and Gynecology Department at the University of Michigan. Dr. Peahl is an assistant professor in obstetrics and gynecology and a health services researcher at the University of Michigan. She recently served as a visiting scientist for Maven Clinic, the largest online digital women's and families services clinic. Her research focuses on how to improve the effectiveness, efficiency, and equity of reproductive health care through developing, studying, and disseminating high-quality maternity care interventions. She is nationally recognized expert on prenatal care redesign and innovation and has completed seminal studies and thought pieces on how to best incorporate patients' preferences and needs into right-sized prenatal care plans that match patients' needs to services delivered. She is the co-director of the Michigan Plan for Appropriate Tailored Healthcare in Pregnancy, otherwise known as MiPATH, and the chair of the American College of Obstetricians and Gynecology Redesigning Prenatal Care Initiative. Briaa Robinson is a health equity project manager at the University of Michigan in the Department of Obstetrics and Gynecology. She currently supports the promotion of health equity grant with the overarching goal to connect clinical and community partners together to improve health outcomes and eliminate disparities by creating robust systems to link pregnant and birthing people with unmet social needs to their resources in their community. So thank you so much, Dr. Peahl and Briaa, for being here today. Before I turn it over to you for your presentation, I'm going to review a few housekeeping items. So first, this session is being recorded, and the slides and the recording will be shared following the webinar. And then next, we will be monitoring the chat throughout the presentation. So feel free to add questions there. And then we'll also have some designated time for an open discussion and Q&A at the end of Dr. Peahl and Dr. Peahl and Briaa's presentation. And then lastly, we do have a post-webinar survey that will be provided in the chat right now, as well as at the end of the webinar and in a follow-up email. So the survey is due on December 21st. We would really appreciate if you filled that out. And the survey aims to gather primary contact information for the outpatient clinics that provide prenatal care to your patient population. So Dr. Peahl and Briaa will talk about this more in their presentation. So without further ado, I will turn it over to Dr. Peahl and Briaa. Thanks so much.
Thank you so much for that introduction, Christy. We are really excited to be here with y'all today. I'll just pull up my slides and then we can get started. All right. So we are here today to talk to you about the Mom Map project. We'll start with a little bit of background on maternity care and needed changes coming down the pipeline. And then we'll go into your role and how you can help us to be part of this really incredible change process. Briaa and I work with a huge team to do this work. And so we are here just representing this wonderful group that is really working tirelessly to improve maternity care across our state. Our work is broad. We work in a variety of areas to help improve maternity care delivery across the state, and we've tried to summarize it here for you on this slide. All of the work you see here is funded by MDHHS through a health equity grant. And through that grant, we seek to deliver more comprehensive prenatal care delivery that links medical and social care. And we do that through pilot projects across the state. We're also building data and IT infrastructure to support health equity. And that work is being done with MDC, as well as the Obstetrics Initiative, which is a Blue Cross Blue Shield funded quality collaborative. And then we also have developed in collaboration with patients and community members, a statewide patient and community action board. And that really incredible group of people with lived experience helps to inform every stage of what we do. And why do we do it? Ultimately, our goal is to help birthing people and their families not only survive pregnancy, but also to thrive. There's been a lot of focus in recent years on the maternal morbidity and mortality crisis, and we hope first to improve that. But survival is not enough, and we hope to help people move through their transition to parenting and the postpartum period in a way that helps them to really be successful and happy. So if you have been on social media or looked at a news outlet in the past several years, you know that we face a huge maternity care crisis in the United States and specifically here in the state of Michigan. And traditionally, we have thought about that maternal morbidity and mortality as an inpatient issue for hospitals to solve. And here are 3 examples to highlight that. The first is a patient who has a postpartum hemorrhage or significant bleeding at the time of birth, which requires more procedures in the operating room and ultimately a blood transfusion. The second patient is admitted with severe blood pressures in pregnancy, also known as preeclampsia, also with kidney damage and difficulty breathing, and she has to be admitted for the rest of her pregnancy and ultimately requires a preterm birth. And the third example is a patient with a postpartum infection who comes in 3 days after her delivery with fever and chills and is found to have a retained placenta, which is the source of that infection.
Dr. Peahl, sorry to interrupt. We had one person say it's a little hard to hear. How is everyone else? Is everyone else hearing okay? I want to make sure it's not a universal thing. I can hear okay. It's maybe a little quiet.
Oh, sure. I can try and speak up. Does this help?
That helps. Mary, did that help for you? Mary Greeley?
Yeah, it helps a little bit. I'm trying to solve it on my end if it's not universal. Thank you.
Absolutely.
Thank you for stopping us. So if we move upstream from that traditional thought that morbidity happens in the hospitals, we see that there are many upstream drivers that start during pregnancy, and that many of these are preventable or missed in the outpatient setting prior to when people are admitted for birth. This can be seen again through those 3 examples. The first patient who may have poor access to quality care. She had difficulty attending her prenatal appointments, missed her 3rd trimester labs when anemia is typically identified, and didn't receive iron, which put her at greater risk of transfusion. Or the second patient who had missed opportunities to manage risk factors. This patient with hypertension had lost insurance coverage between her pregnancies, entered pregnancy with poor control of her blood pressures, which put her more at risk of developing complications. And additionally, her provider did not talk to her about aspirin, one of the few preventions we have for high blood pressure. And then finally, the patient with the postpartum infection had really rushed prenatal care visits because she had to get back to work and couldn't afford to take more time off. Because of that, she missed really important education on warning signs and didn't know when to come back with these initial early signs of infection, and instead presented late with the need for admission. So improving maternity care outcomes really requires moving upstream and improving prenatal care quality and access. And addressing barriers to care can really help with the receipt of recommended services that directly affect care outcomes. You can imagine a future where all patients have access to quality care. And patient 1 has no complications. Her anemia is identified and treated, and she navigates birth without a transfusion. The second patient, adequate management of her risk factors could mean entering pregnancy healthy with good blood pressure control and receiving all evidence-based interventions. And finally, having access to education and timely diagnosis when partnering with patients could have helped our patient with a postpartum infection present early and not require such a severe treatment course. So when we go back to the basics, prenatal care is the critical preventive service to help improve the health of birthing people and their infants. And in the medical model, we think that patients discover their pregnancy, they receive some evidence-based services, and then they have good outcomes. That's how ideally it would work. But birthing people across the country are not receiving the most basic evidence-based services. A study conducted in claims data for commercially insured patients showed that less than half of birthing people with commercial insurance received 8 of 8 recommended laboratory tests, vaccinations, and ultrasounds in a timely way. That is striking. This is the most basic of prenatal care, and half of patients with commercial insurance aren't getting it. And why is that? Well, receiving evidence-based care isn't straightforward. When patients discover their pregnancy, they have to first get access to prenatal care, which can be quite challenging in our state. We've heard about birthing people calling multiple clinics in hopes of finding a place that they can receive care. After that, patients need to receive those evidence-based services, and there are a variety of reasons why those may not be completed. And then ultimately, the compilation of those leads to outcomes. All of the steps in this process are influenced by social drivers of health, the conditions in which people live, work, and play. And these all influence people's ability to be healthy and drive access to care, people's ability to receive evidence-based services, and directly affect outcomes. Our health system currently focuses primarily on medical care, and that misses these key drivers of outcomes. You can see how unmet social needs affect this care pathway when we don't ask and don't acknowledge them. For most patients, when they have their discovery of pregnancy, they don't receive that assessment for social drivers of health. In turn, these limit their access to care, may lead to missed evidence-based services and adverse outcomes. Traditionally, maternity care professionals have really thought about social needs as a problem that only patients with Medicaid face. And that can be really a missed opportunity, as we know these social needs account for 80% of health outcomes, and many patients with both commercial and public insurance have unmet social needs. A recent survey completed by my team showed that 2/3 of patients with commercial insurance and 90% of those with public insurance face at least one unmet social need. So what can we do about it? The National Academy of Medicine provides a really nice framework for improving outcomes that goes beyond just medical care. Across the top, you can see that framework we outlined: discovery of pregnancy, access to care, receipt of services, and outcomes. And in the National Academy of Medicine framework, when patients first present for care, they receive assessment for their social drivers of health. In other words, a standardized screening. And if unmet social needs are identified, there are 2 care pathways to follow. The first is that traditional care pathway of assistance or providing resources. And the second is adjustment or making care more accessible. You can imagine a patient who has transportation barriers. If these are identified in the first intake appointment for a prenatal visit, the team can provide assistance like ride vouchers or a rideshare program to help get them to the appointments where they need to be seen. That, at least temporarily, resolves the unmet social need and improves their care access. But simultaneously, care can be adjusted to be more accessible, layering in virtual visits or streamlining services to minimize those transportation needs. Both of these together can lead to improved care access, the receipt of evidence-based services, and improved maternal and infant outcomes, hopefully increasing that rate of completion of evidence-based services from 50 to 100%. So I briefly shared one example of how we can assist and adjust care. Assistance, I think, is the piece that clinicians are typically more familiar with. This is providing patients with things like resource guides, referrals to social work, partnerships with community-based organizations, or even community-based hubs like the Community Health Innovation Regions or SHIREs that are in some locations across the state of Michigan. And even partnership with social needs platforms, app-based or web-based programs that maintain lists of available resources. Adjustment is the piece that folks tend to be a little less familiar with. And that is something that is squarely in the clinician's hands, adjusting care delivery so that it can be more accessible and can better fit individual patient needs. In maternity care, we have a couple of options for this. The first is targeted visit schedules and virtual visits for birthing people who are considered average risk or don't have significant medical and pregnancy comorbidities. Targeted visit schedules are safe and are the primary care delivery model in most peer countries that have better care outcomes than the United States. There's also randomized controlled trial data to support the safety of virtual visits when done properly with home monitoring using home blood pressure monitors. And then finally, group prenatal care can be an amazing tool for individual patients who are facing social isolation or other social related adverse social drivers of health. I am excited to say that our team has been leading new national recommendations from ACOG, the American College of Obstetricians and Gynecologists, or leading maternity care organization in the US. And these new guidelines coming down the pipeline in fall of 2024 will support a more flexible, tailored approach to prenatal care delivery that accounts for not only individuals' medical and social needs, but also their preferences. And this care model is really designed to move upstream of the adverse outcomes we're seeing, build trust with birthing people, and improve the overall delivery of care. And so you can see a summary of that model here. This new model of care is called PATH, the Plan for Appropriate Tailored Healthcare in Pregnancy. And in PATH, from the moment a patient presents for care, we should screen for medical and social drivers of health, and then gather the patient's preferences. What's important to them in their care? What do they need to successfully navigate pregnancy and the postpartum period? And from that, we can determine a tailored prenatal care plan, tailored in 3 key areas. Visit frequency and monitoring. So how often are we seeing birthing people and measuring key parameters? Second is telemedicine and care modality. How are those visits delivered? Do we use virtual visits or in-person care? Do we use group care? And then finally, support for social and structural determinants, which will include this recommendation for both assistance and adjustment of care. And I've just completed a national listening tour with over 110 individuals from 25 groups representing patients and providers, payers, public health leaders, and policymakers. And everyone across the country is trying to figure out how to do this. And in Michigan, we have the chance to be the leaders and really show the rest of the country how this is done. But there are still a lot of unanswered questions that limit our knowledge of how to improve prenatal care quality. And that's the space that our group is working in to improve care. So first is a shocking question to me, but one that none of our payer leaders or leaders in MDHHS can answer. And that is, where is care delivered? There's actually no comprehensive list of all of the locations where a birthing person could go to receive prenatal care. The second question is, how is that care delivered? We don't have data on what visit schedules and modalities are being used across the state, or the delivery structures that are in place to support birthing people. And then finally, we lack data on how social needs are identified and managed. We don't know if or how clinics screen and manage identified social drivers. We know on the hospital level, less than half of birthing hospitals in Michigan are asking at all about social drivers. And of those, only about a third are doing so systematically. And so we suspect the same gaps exist in the outpatient setting. So the MOM map seeks to really fill these existing gaps in knowledge and prenatal care practices across Michigan. MOM map stands for the Multi-Site Opportunities for Michigan Maternal Health Assessments and Prenatal Care. And that's a mouthful, so we just call it the MOM map. And this project is funded by the Blue Cross Blue Shield Central Reserve Fund for the Collaborative Quality Initiatives. And this project has really 3 big goals. The first is to identify prenatal clinics and practices, and we plan to do that with semi-structured interviews across the state of Michigan. The second is to collate all of that knowledge into the MOM map, a comprehensive resource across the state that can be a resource for patients and providers, and also serve as a platform to inform future initiatives. And then finally, from all of these incredible clinics we identified, we plan to convene social needs change agents, those who are at the cusp of implementing new prenatal care programs, bringing clinical and community partners together to build for a better future together. MomMap has several domains that we'll be querying, understanding clinic structure and infrastructure, different healthcare professionals who provide services, what public and support services are available within the programs, the clinics, how is prenatal care initiated at these different locations, and then how is care delivered in terms of the schedule, use of virtual care, remote monitoring, and group prenatal care services. How are special populations like those with mental health comorbidities, substance use, or chronic medical conditions cared for? And then finally, what are the current practices around social drivers of health? How are clinics currently assessing for unmet social needs, providing assistance and adjustment? Our vision for the future is to continue to expand our current work. We started with a pilot in Kent County. We are now expanding to Wayne, as well as to Flint. And then MomMap will provide the infrastructure to build so that every clinic across the state is able to provide the highest quality of comprehensive prenatal care. So where do you as the POs come in? We are hoping for your help in identifying where prenatal care is provided across the state of Michigan by really helping to facilitate connections with the physicians in your network who provide prenatal care. We have a variety of pathways for that, and the survey today is the easiest approach to doing so, where you'll be able to help connect us with the individuals who are providing these critical services. We have all kinds of resources available in the event that you wish to reach out directly to those clinic contacts, and we're happy to talk more about that at the end of this call. So we would love to learn a little bit more from you with these discussion questions here, and we'll pivot to that momentarily. For the portion of the webinar, I do just want to say thank you for your time, thank you for your help, and for being willing to contribute to improving care for birthing people across the state. We're happy to take any questions before we move into the questions that we have for discussion today. Thank you.